investigation.
अच्छा
We've taken the indication sedation out of the talk.
अच्छा ठीक है
That's why I was discussing.
अच्छा ठीक है राइट ओके
You know, the senior people come to with complications, yes.
राइट ओके फाइन
So we'll go straight to complications.
Shall we? I'll just briefly touch on the indication. ताकि
What I was
we'll just run through that.
thinking, what my view was, it's up to
Acha.
you. My view was,
Right, okay.
that's what we just touched.
Okay,
And
fine.
we can keep going in, but complications I was very concerned
Right.
about because they should know what the
Okay,
risks
fine.
are and
I'll
we
just
can throw it.
we'll just quickly run through it. We just briefly discussed that. In fact, in discussion, so all those indications are there, right? In assessment of colitis or Crohn's disease, we do it for 3 reasons: to determine the extent of the colitis, activity, and surveillance. To diagnose ulcerative colitis, all you need is a rigid sigmoidoscopy. But to determine the extent of the disease, you need colonoscopy. To determine activity, you might need a colonoscopy. Or if it's a fulminant colitis, then you need a flexible sigmoidoscopy. Because in acute fulminant colitis, colonoscopy is hazardous. Surveillance purposes, because there's a high risk of developing colorectal cancer in patients with inflammatory bowel disease. They should have a surveillance colonoscopy after 10 years of the disease, and then it should be done every 3 years. After 20 years of the disease, it should be done every 2 years, and after 30 years of disease, every year. If they've got something like primary sclerosing cholangitis, it should be done on a yearly basis. Indication: unexplained diarrhea, change of bowel habit to more looser frequent stool lasting more than 6 weeks. You don't do it if you have a diarrhea for 2 weeks or 3 weeks. Because if it's infectious colitis, it's usually self-limiting. Change in bowel habits of any sort in anyone over 60 years of age, and in those who are over 40 years of age with bleeding. But as Dr. Saad mentioned, there's a high incidence of colorectal cancer in younger patients here, so you do it in younger patients if you are suspecting them. Screening purposes: in most of the Western countries nowadays, there's a national bowel screening program, or if there is family history of familial adenomatous polyposis syndrome or HNPCC or any of the cancer high-risk groups. So surveillance is done in those class of patients: previous polyp or cancer, inflammatory bowel disease, patients who have had ureterosigmoidostomy, and acromegaly. Acromegalic patients get it done every year because of the high levels of growth hormones. Most important is in what circumstances is colonoscopy not indicated. It is not indicated if there is withdrawal of consent by the competent patient, right? Another case in which colonoscopy is not indicated is endoscopist is not accredited or incompetent to perform the procedure. Not because somebody has bought you a new colonoscope and you start doing it. That is not ethical. It should not be practiced. Uncooperative patient who is unable to be sedated, if he's jumping off the bed, the procedure is painful, you should stop. Contraindications: acute severe colitis, because it is hazardous, you can cause a perforation or toxic dilatation of the colon. In toxic megacolon, definitely not indicated. Acute diverticulitis: if you find acute diverticulitis with pus coming out of diverticuli or blood coming out, stop your procedure there. Don't go further, because you'll cause a perf or cause something terrible. Acute abdomen: colonoscopy is not the procedure of choice in acute abdomen. It is contraindicated. In acute abdomen, you need your clinical skills to diagnose the case, and you need imaging, whether it's a plain abdominal X-ray or a CT scan. Perforated viscous: again, you don't need a colonoscopy, you do need imaging. The reason for contraindication is because there are 3 different procedures involved in colonoscopy: the bowel prep, the sedation, and the procedure or therapy. If somebody is not well enough to take the bowel prep, you can't do a colonoscopy. If somebody is at risk of sedation, like those with COAD who are frail patients with any respiratory or cardiorespiratory disorders, then if you can do it without sedation, fine. If not, then you shouldn't do it. The procedure or therapy, those who can't. Complications. The main complications that you get out of colonoscopy are perforation and what else? Bleeding, yeah? Okay. Perforation is one of the dreaded complication of colonoscopy. Now, obviously, when we talk about complication, we talk about the procedures as a whole, the numbers as a whole. But in a diagnostic procedure, it should never happen. I mean, why would you cause a complication if you are just having a look around? I've seen people cause perforation in diagnostic procedure because their technique is bad, they are rough, right? And they cause tears of the mesentery or they cause tear of the colonic wall. So that should never happen in a diagnostic healthy colon. Yes, it is acceptable because if you carry out polypectomy or you carry out any therapeutic procedure like dilatation of the colon or treat a bleeder or something, do APC, then in that case, it is well-recognized complication. Or if there is extensive diverticular disease, then it is possible. But as I said, if you are not up to it, if you find it difficult, there's extensive diverticular disease, then do not proceed. Get somebody more experienced to do the procedure for you. And in patients with severe colitis, high risk of complication. So again, we do not do a complete colonoscopy in acute severe colitis. What's the point of doing it? Because if you've got active acute fulminant colitis, whether it is left-sided colitis, pancolitis, or whatever, the treatment and management is exactly the same.
Anyone see perforation, colonoscopic perforation, anyone? Two. The rest haven't. So what was after surgery? After surgery, okay, fine. What did you do? Well, just wanted to ask Bakar, so before you move on to
Yes, okay,
what you do, I just wanted to know what they've done.
I've seen a couple, but then I did one myself.
Was that a diagnostic?
That was diagnostic for bleeding PR. It was massive bleeding. And so all of a sudden I found myself looking at the peritoneum.
Oh, right, okay.
So we stopped there and we took that patient after preparation to theatre and we had to surgically correct.
Right, okay.
What about you?
It was one of my colleagues, you will see the sky under the scope. So what we did that because the bulb was cracked, so he was taken to theatre, and what they used to do is do a divergent colostomy rather than do a primary repair. Then he was called back after 6 weeks to do the primary response.
Right, okay.
Were the patients actually told, and this is bringing back to consent, did they have any idea that they were going for this little procedure, which is what we tell them, and they would end up having divergent colostomy, or they would end up getting surgery? The reason why I raised this point was twofold. One, we discussed the management of complications, but I will take us through it. But the second more important thing was that if in consent, you haven't mentioned the possibility, and this happens, then you've got a big problem in front of you. But if you've mentioned it, then you don't. So I think that brings us to the fact that when you're taking consent, you need to inform the patient about the risk and complication, and hence the emphasis was more on this than other aspects of basic training that we generally did. And so we're just dwelling with this idea. So you can go ahead. Sorry.
I think in a valid consent, you have to give the patient an idea of what's the risk of complication. Because there's a big difference if the risk is 1 in 1,000 or the risk is 1 in 50, right? Because the patient has to be mentally prepared. If I'm doing an ERCP, the risk of pancreatitis is 1 to 2%. But if I'm doing an ERCP in a patient with sphincter of aortic dysfunction, the risk is about 20 to 30%. So I have to pre-warn the patient. Equally important, if you are going to take a big polyp out, the risk of perforation is almost 1 in 250, or even a flat, very extensive polyp, if you are doing ESD, it's 1 in 50. So there's a difference there. If you are doing a random diagnostic colonoscopy, then you quote the figure of 1 in 1,000, which is from a lot of different series, which varying from 1 in 500 to 1 in 2,000 in different series. If patient asks you, can I die from it? we normally don't tell them that they can die from it. Then you can give them a straight answer that yes, there have been deaths associated with it, but the incidence is very low, like 1 in 2,000, 1 in 5,000. So that's how you carry out the consent or the risk. Anyway, the important thing what Dr. Saad wanted to ask you was, what do you do with a complication? The first thing is to be honest and own it, not push it under the carpet, because if you don't deal with it, somebody else would deal with it, and it would be a bigger embarrassment for you. If a complication occurs, it's a recognized, well-recognized complication, like perforation occurs, a well-recognized complication of colonoscopy. Own it, inform the patient that it has gone wrong, and what is the treatment. Because if you do all that and carry out the treatment like surgery or conservative treatment or whatever, admit them, then you've done everything right. Nobody can accuse you of any malpractice. But if you pat him on the back and say everything's all right, theek ho jayega, and send him home, and somebody he comes in with a acute peritonitis or something, acute abdomen, is in septicemic shock and dies from it, then he's, even at that stage, he's a higher risk for surgery. So then that is unethical. And that is something which should be, defined as professional misconduct. Serious. So the first thing to do is to own it and deal with it immediately in a safe manner. Right. Things that are, associated with a poor outcome is increasing age. Anyway, elderly, frail patients are at increased risk of any problem. Significant comorbidity, people who have cardiovascular disease, hypertension, diabetes, chronic obstructive airways disease are at increased risk of most problem. Delayed recognition of perforation. That could be, as I said, intentional if you try to push it under the carpet, or unintentional without realizing that patient has had. But unintentional is very unlikely, because if your patient is in the recovery room, the nurses will tell you that the patient is in pain, because if you cause a perforation, it's not going to be painless. So when the patient wakes up, the effect of sedation and the analgesic wear off, they are going to be in pain. So their abdomen will be distended, they'll have no bowel sound, and the nurses will ask you, okay, how can we send them home or not? So that is important. So delayed treatment is associated with poor outcome. So the sooner you treat them, the better the outcome. Poor bowel prep, as Dr. Saab mentioned, if the bowel prep is good, the outcome is going to be good. Another well-recognized complication of colonoscopy is bleeding. Again, why would you get bleeding in a diagnostic colonoscopy? Highly, highly unlikely, because unless you are really ramming the scope against the mucosa, then you can, but normally you wouldn't. Bleeding from pinch biopsy is very, very, very rare, highly unlikely. Even if the patient is on anticoagulant and they have their INR in the therapeutic range of 2.5 to 3.5, still very unlikely to get bleeding from a diagnostic biopsy. Right? So it only can occur during therapeutic endoscopy, and that is like polypectomies or anything. Usually occurs in the setting of when we do polypectomies, and most of the time, as you take the polyp out, the thick stalk, a vessel, has missed the cauterization or coagulation, and you see a spurter or an ooze. And the thing to do is, first thing is when you are dealing with bleeds, is not to panic and not to take because when you do your polypectomy, don't take your snare out immediately. Keep it there. Because if the stump is bleeding, you might be in a position to put it around the snare around the stump and just close it without doing anything. Just the tamponade or holding it tight for a few minutes will buy you time. You can then coagulate it or put something around it. So the other important thing is that you can get delayed hemorrhage after polypectomy. You might not see any hemorrhage, it may be well sealed, everything, but as the clot breaks off and everything, you might get a delayed hemorrhage 2 to 3 days later, a week later, or even 10 days later. So it is important to warn the patient that Everything might be fine, but don't be surprised if you see blood coming out. And if you do see blood coming out, the first thing to do is get straight back to hospital or get in touch with you. Right. Right. Important thing. If you are trying to take a polyp out, make sure you've got a comfortable access to that polyp. Not that it is right in the corner and you are trying to get it from an edge and then you try to excise it. Because you might be able to excise it, but if that polyp starts bleeding, then you are in big trouble. Because if you can't get to it, how are you going to stop the bleeding? So, as you all know, the suction channel of the colonoscope is at the 5 o'clock position. So when you are carrying out any therapeutic procedure, bring your polyp to the 5 o'clock position. It should be within your easy access. If you can't get easy access to it, or if you don't feel that you are able to take that big polyp out, then send it to somebody who is more experienced and able to do it. Don't do anything. If you are a lightweight boxer, you do not go and fight Mike Tyson or one of the heavyweights because he'll knock you out. So if you are a lightweight colonoscopist, don't do heavyweight jobs. Secondly, any procedure you carry out, make sure you've got all the equipment available. Not that somebody sent you a snare from outside and you say, oh, well, I'll start doing polypectomy. You should have hemostatic equipment available with you, like clips, loops, APC, or gold probe, or coag graspers. You should have all your armamentarium or hemospray. Right, that's a separate topic. Bowel prep is part and parcel of colonoscopy. We use various types of bowel preps. In UK, the common one that we use are phosphate-based products like Picolex, but that's going out of fashion. We use most of the non-absorbable osmotic like movie prep or clean prep. The advantage in using the non-absorbable movie prep or clean prep is that because phosphate-based problem in patients with renal failure, because excess amount of phosphate is absorbed, it can be hazardous for patients with renal failure and should not be given to patients with renal failure. If somebody's got renal failure, you should seek advice from your nephrologist, or simply don't use the phosphate base and use the thing like movie prep or clean prep. I don't think you have movie prep as such here, but the stuff called move call is the same, but it's used in industrial doses.
We have phosphate-based most.
Yes, yeah. But phosphate-based, you can. The other hazard that you see with phosphate-based bowel prep is that you might see abscess ulceration in the bowel. That is an effect of the bowel prep rather than actual colitis.
That sometimes leads to major issues because sometimes there are lots of little tiny ulcers that you're seeing and you take biopsy and it comes back saying non-specific colitis.
And you start.
Having diarrhea, you've seen some ulcers, you've taught a biopsy which says non-specific colitis, you label it ulcerative colitis. And then the patient's treated like ulcerative colitis
For the rest of their life.
months until he or she comes and sees somebody else who says, hang on a minute, this is not colitis.
So when you give bowel prep to elderly, frail patients, be wary because it will make them go to the toilet, their mobility might not be as good, and they may get postural hypotension and fall. So always a good idea to use, assess these patients before you give them bowel prep, because if your patient is not up to a colonoscopy, then you should do alternative procedures. And what are the alternative procedures you can do?
CT or the barium.
Yes, sir.
Barium.
Exactly. Because the important thing to remember is CT colonography does not require bowel prep, right? Sometimes they give them low dose laxatives, but it's not the same as bowel prep, right? It's done with fecal tagging. Right. Mispathology is a complication of colonoscopy and should be mentioned in the consent. Even in very experienced hands, there's a 5% chance of missing a polyp or a lesion. Because people, when they've done back-to-back colonoscopy, like one, they've completed a colonoscopy and another clinician has gone in to do, they've seen that there's a 5% risk of missing a significant lesion. And the importance of that is that if you do a colonoscopy, it is normal, the patient comes back to you with change in bowel habit or bleeding per rectum, then they should be re-investigated. So to prevent complications, it's always better to, prevention is always better than cure. Make sure that you risk stratify your patients. That patients who are elderly with comorbidity, patients with significant CVS, respiratory, renal, malignant disease, they would have a high procedural mortality rate. Another important one to remember is patients with Addison's disease. Very rare, but if you carry out a colonoscopy without adequate steroid cover, they can end up in Addisonian crisis, which can be near fatal. So always important, diabetic patients, normally in all our units we have a policy for diabetic patients. You should, get the advice from your endocrinologist. So you shouldn't do colonoscopies in fulminant colitis, and in patients with previous radiotherapy, there is risk due to strictures, angiodysplasias. Anyone who has had previous abdominal or pelvic surgery, like the commonest scenario is women who are post-hysterectomy. They are a nightmare because of adhesions. It is, even in very good hands, they are more challenging to do, right? Bleeding disorders, normally if patient have bleeding disorder, we normally consult our hematologist. They can give them factor 8 or whatever, so usually give them advice. The other problem is people who have got conditions like von Willebrand disease or hemophilia are also at risk of CJD, variant CJD. So those are the patients, if you carry out any therapeutic procedure or biopsy through your biopsy channel, then that can infect your scope and potentially infect other patients. So beware with hematological disorders. Other conditions like, you have to be aware of, all these should be covered in your pre-assessment. So they've got allergy to sedatives or they are clinically unstable patients, you shouldn't be doing them. The important thing is if there are any of those high-risk things available, are present in the patient, can the procedure be reasonably deferred or alternative procedure carried out like barium enema? Barium enema is hardly done, they stopped doing it in our hospital. We do CT colonography. Right, okay, shall we stop there or? Fine, okay, thank you. Otherwise, you'll all go to sleep.
Any questions or any points that you want to raise?
Regarding the patient trial